this evening's event, a community forum to address a Capital Region health system merger. My name is Corinne Carey, and I'll be moderating tonight's event. Before we begin, I'd like to acknowledge the Mohican people. It is with gratitude and humility that we acknowledge that the Sanctuary for Independent Media resides upon the ancestral homelands of the Mohican people, who are indigenous peoples of the lands of New York. Despite tremendous hardships and being forced from their lands, today their community resides in Wisconsin and is known as the Stockbridge-Muncie community. We pay honor and respect to their ancestors, past and present, and we commit to building a more inclusive and equitable space for all. Tonight's event is sponsored by the Schenectady Coalition for Healthcare Access. The coalition was formed to educate the administrations and the public about the risks and losses to our community from Ellis's partnership with SPHP. In addition to education, members of the coalition seek to advocate equitable access to evidence-based, inclusive, and comprehensive patient-centered care, including comprehensive reproductive care, infertility care, LGBTQ+ inclusive care, gender-affirming care, and end-of-life care within our local community. You can find out more about the coalition by visiting us on the website, www.schdy.org, and we'll be placing that in the chat box so you can see the link. The event is also co-sponsored by our community partners, Local Care Midwifery, the New York Civil Liberties Union, Rosemarie Perez Jaquith, the Niskayuna Town Board member, proclergy.com, and Progressive Schenectady. I want to thank our host, the People's Health Sanctuary, a program for the Sanctuary for Independent Media. For those of you not yet familiar with the Sanctuary, we are a nonprofit community organization based in North Central Troy, New York, just across the Hudson River from Albany. We operate a block-wide campus of activities. If we weren't in the midst of a global pandemic, we'd be sitting in the Sanctuary for Independent Media, our headquarters that doubles as a telecommunications facility and performance venue where we host speakers, independent film screenings, and live music. It's also home to 2 recording studios for our community radio station, WOOC 105.3 FM. We host a volunteer-driven nightly news and public affairs show called The Hudson Mohawk Magazine, which is how I first got involved here as a radio producer. I'd like to introduce you to Ariella Zamchek, council member for the People's Health Sanctuary and Media Sanctuary board member, to tell you a bit more about the Sanctuary. Ariella?
Thank you, Corinne. The Sanctuary for Independent Media houses a tremendous variety of activities that help address social change and social justice in North Central Troy. And it's a place where people with almost any skill set or interest can get involved. Just to name a few of the projects, we have an urban garden, College City Growers, which tackles food insecurity, the Nature Lab, a citizen science research and education center that focuses on environmental justice, as well as many performance and media projects. I became involved when I was a new Troy resident working in public health and missed the sense of community that I was used to feeling when I saw patients as a family doctor. I was looking for places to use my skills and work in community health in some capacity, and I found a perfect match with the People's Health Sanctuary. The People's Health Sanctuary grew out of a direct call by our local community to increase health justice programming. Its mission is to support open sharing of health knowledge and support independent health goals in opposition to the top-down hierarchical approach typically seen in clinical medical practice. We have a growing network of people to share skills and build an accepting, stigma-free space where various health modalities are welcomed and accessible to everyone. We will be located on the 2nd floor of the brand new Nature Lab building, the newest addition on our block, which is scheduled to open this spring, and we're currently fundraising to finish renovations. The donation link can be found in the chat. I'll post in a minute. And we'll be live streaming this event on Facebook and also uploading an edited version of the video to our YouTube channel, Sanctuary TV. When this is all over, all of you, our event registrants, will receive a link. I'm going to turn it back over to Corinne to go over some housekeeping and introduce tonight's panelists.
Thank you, Ariella. If you have your camera enabled, I want to remind you that because this event is being recorded and streamed live to Facebook, you'll be visible on the recording. Similarly, we'll be making the resources and discussion shared in the chat box available to participants in the future. And I promise you, the chat box is going to be chock full of resources and links that you'll want to take a look at in the future. In order for you to ask a question or chat with the panelists or attendees, look to the bottom of your screen and you'll see a chat box. If you have a question, please type it there and we'll call on as many of you as we can. And we'll try to unmute some of you during the live question and answer section if you want to ask your question live. So please indicate for us if you'd like to ask live or if you'd like us to read the question. You can also send a private message to anyone through the chat function as well. I want to note here that the questions we'll be taking this evening are for the panelists. Although I'm very grateful that we're joined tonight by officials from both Ellis Hospital and St. Peter's, they will not be speaking tonight, nor will we be asking them to answer any questions. We're hoping that we can learn from our experts what they've seen in other jurisdictions and that our local hospital officials keep these questions in mind. I also want to let folks know some of the things we'll talk about tonight are difficult subjects and may bring up feelings and emotions that some participants may need help to navigate. We're so grateful that local mental health professionals from the Schenectady County Community Services are here tonight, and you can connect with them via private message in the chat box. We're also joined by some elected officials, and their constituent services folks are also available to participants tonight. Additionally, you can seek help for emotional distress by calling Project Hope, and we'll be posting all of these resources in the chat box. This event will run tonight until 8:30 p.m. We're going to hear from 5 different speakers and we'll introduce them in turn. Right now, it's my pleasure to turn this event over to Michelle Osterlich. Michelle is a Schenectady County legislator and chair of the legislature's Health and Human Services Committee. She is the reason that many of us became aware of the implications of this hospital merger for our community, and we thank her for her vigilance. Michelle?
So much, Corinne, and good evening, everyone. Welcome to the community forum organized by the Schenectady Coalition for Healthcare Access, hosted by the Sanctuary for Independent Media. We are reassured to know that many, many others share our concerns. Over 260 people registered for tonight's forum. We appreciate each and every one of you for your presence, including leaders of the community organizations that are very active in Schenectady County, medical practitioners, government officials, members of the press, and the following members of clergy: Reverend Bill Levering, Reverend Sarah Barron, Reverend Abby Norton Levering, Reverend Jonathan Vanderbeck, Reverend Donna Leah, Reverend Tim Coombs, Rabbi Matthew Cutler, and Reverend Lynn Gardner. We'd also like to specifically acknowledge the following elected officials: Niskayuna Town Council member Rosemary Perez-Jaquith, Schenectady City Council members Carmel Patrick, John Palmini, Karen Zalewski Waldzunas, Schenectady Mayor Gary McCarthy, Albany County Legislator Sam Fine, Schenectady County Legislators Richard Russo and Sarah Mae Pratt, Assembly Member Phil Steck and his staff member, Jess Singleton representing State Senator Michelle Hinchey, and Colleen Williams representing Congressman Paul Tonko. If I've missed anyone, please let me know by private chat and I'll acknowledge you later in the program. Additionally, as Corinne said, we are thrilled to have Paul Milton, President and CEO of Ellis Medicine, and Jim Reed, President and CEO of St. Peter's Health Partners, along with administrators, board trustees, and practitioners from both hospitals, and they're on tonight's Zoom. Their names are in the chat right now. This forum is an opportunity for all of us to learn from our panelists who are experts on these types of mergers, and panelists who are leaders in our community, here to highlight the expected impacts of the merger. We also hope that this forum will be an opportunity for the hospital leaders to hear from members of the community, your personal experiences, your concerns, your questions, and your priorities. But again, we want to be very clear. Ellis and St. Peter's leadership teams are here as guests for listening purposes only. They're not in a position to answer questions tonight because they're early in their due diligence and in negotiating the terms of their partnership. We hope that what they hear tonight from you, the community, will help inform those decisions. And we expect that the hospitals will address those questions and concerns concerns raised tonight when they're at a point in the development of their partnership to more fully respond. We've recently been told that Ellis and St. Peter's may wait until the pandemic crisis and the financial impact has passed before they resume due diligence and negotiations. That could take up to a year. Regardless, Paul Milton has promised to hold their own forum well before Ellis and St. Peter's file with the Department of Health. For all of those reasons, we will not be directing any questions or asking for any comments from hospital leadership tonight. Now, I'd like to talk for a minute about Ellis's need for a partner and its choice of St. Peter's. There were several reasons why Ellis wanted a partner, based on public statements and private conversations with Paul Milton. One was for financial reasons, and so members of this coalition looked at Ellis's public pre-COVID financial statements with some professional help and with a critical eye. We found that it does make sense, very good sense, to partner. Pre-COVID, Ellis had healthy reserves, and there was no need to worry about any immediate insolvency, but to continue to invest in programs and facilities and to maintain high quality care that is needed for long-term solvency, it needs a partner. Without one, hospitals that are unable to make those investments survive for a while, but only until public confidence is too far gone. Patients stop choosing that hospital, and like a slippery slope, they fall to insolvency, which can happen rather suddenly. The administrators were being proactive for sure, but we can't disagree with their strategic plan. After a relatively exhaustive search, Ellis's board chose St. Peter's. In many ways, this choice makes sense. St. Peter's is financially strong and part of a large healthcare system, Trinity Health, which has even bigger assets. St. Peter's is community-minded and has a significant history of mission-driven community outreach programs, not just in Albany, but in Troy, where they've expanded. If the goal is to maintain a well-resourced local hospital, St. Peter's has a track record of doing just that. Moreover, St. Peter's will help with the significant challenge of recruitment and staffing. There can be no denying it's hard to recruit physicians and practitioners to come here. Finally, St. Peter's Health Partners is already a trusted part of our medical community. Sunnyview and Cardiology Associates of Schenectady are a few examples of local St. Peter's providers. Because of these reasons, it doesn't seem fruitful to simply oppose this merger. We want to make sure that it's done with the best possible terms for our community's needs. We want to minimize any loss of services, and we want to explore ways to fill gaps in services that are unavoidable with this partner. There have already been changes at Ellis since the announcement of the partnership with St. Peter's. We don't know if they were planned in anticipation of the partnership or just were part of Ellis's independent strategic planning, but here's what we do know. The dental clinic and residency program are being eliminated. Visiting nurses service is being eliminated, and all patients are being transferred to new providers. The emergency department is being outsourced, and the McClellan campus is up for sale. On top of these changes, as many of you already know, anytime a non-sectarian hospital like Ellis associates with a Catholic hospital or healthcare system like St. Peter's and Trinity Health, religious restrictions will be imposed. Our panelists will explain these religious restrictions in depth, how they are typically applied in situations like ours, and how they may be able to limit their effect as other communities have done in similar situations. On their face, though, the religious restrictions known as ethical and religious directives, or ERDs, are unambiguous. For example, there's a blanket prohibition against providing any contraception, IVF, tubal ligations, vasectomies, and terminations of pregnancy. We've been told, however, that if Ellis merges with St. Peter's, most birth control and tubal ligations will be allowed. However, no abortions may be performed. I hope that sets the stage for our panelists. Now, I'd like to introduce our first panelist. Lois Utley Mpp is Women's Health Program Director for Community Catalyst, a national consumer health advocacy organization. She has worked for more than 20 years to protect access to comprehensive reproductive health services, LGBTQ inclusive care, and end-of-life options when community hospitals propose to merge with nearby Catholic hospitals. She's published research about the growth of large Catholic health systems and is founder, director of the MergerWatch project, advised community coalitions in 38 states, including several in New York State. Now based in Manhattan, Lois serves on the steering committee of the statewide coalition called Healthcare for All New York and coordinates the work of the organization Community Voices for Health System Accountability. Formerly a Capital District resident, she's very familiar with our community. When living here, she served as the Vice President of Family Planning Advocates of New York State, Director of Public Affairs for the New York State Department of Health. And on top of all that, Lois is an award-winning reporter and editor covering New York State government for the Albany Times-Union. On a personal note, Lois has been invaluable to this coalition. We are grateful for her experience, thoughtfulness, and willingness to help. She's here tonight to provide the background to the many layers typically seen in these hospital mergers. Lois, I turn the screen over to you.
Well, thank you so much, Michelle. I'm delighted to be back in the Capital District, even virtually. I lived among you for more than 20 years and still have many friends there. And I must say, I'm so impressed by this coalition. Big kudos to Michelle and everybody who helped put this event together. You're doing a terrific job. So let me talk first about the trend of hospital mergers and consolidation in the health industry. This proposed merger of Ellis Medicine and St. Peter's Health Partners is really only the latest example of ongoing consolidation in the healthcare industry that began in earnest about 20 years ago. Nationwide, 80% of all community hospitals are now part of a system. And for Catholic hospitals, it's even higher, about 98%. So in the Capital District, we've seen Albany Medical Center, right, take control of Saratoga Hospital, Columbia Memorial Hospital, and Glens Falls Hospital, while St. Peter's Health Partners now controls Memorial Hospital in Albany and 2 hospitals in Troy, Samaritan and the former St. Mary's. And of course, Ellis Medicine is itself the product of a merger between Ellis Hospital, St. Clair's, and Bellevue Women's Hospital. So I just want to underscore that if this transaction goes through, the Capital District will go from having 3 hospital systems to only 2. So I'm sure you're wondering, are hospital mergers good or bad? The answer is, it all depends. As Michelle has alluded to, becoming part of a health system can potentially help a struggling community hospital, especially from unexpected events, protecting it, for example, from the financial consequences of a pandemic. It can give a hospital greater access to capital needed for fiscal improvements, things like upgrading electronic medical record systems. I would note, though, that it does not look to me like Ellis Hospital is a struggling hospital now. So, you know, maybe there's a little time to come up with the best solution for Ellis. Consolidation of hospitals is also a frequent tactic to improve hospitals' bargaining power in negotiations with health insurers. You know, the bigger you are, the more clout you have. And this tactic can help improve hospitals' bottom line. But keep in mind that the more hospitals can charge to insurers, the higher your insurance premiums might be. So it's not without some cost to consumers. Sometimes the promises made about the potential benefits of proposed hospital mergers just don't come true. I've heard in 38 states, oh, there's going to be better quality of care, better access to services. Well, I must tell you, the hospital landscape is littered with community hospitals that were downsized or even closed after a merger. Each of these big health systems has a high quality hub center of excellence, and increasingly patients are referred there from the system's other hospitals for certain types of advanced care. So in this way, services can be removed from your local hospital and you expected to travel somewhere else, like perhaps to Albany. Another consequence of these mergers often is that local control of community hospitals is diminished or lost. You know, increasingly, a group of large regional and national health systems is gaining control of most of the community hospitals in the whole country. My team found, for example, in 2018, that 10 large health systems had come to control 70% of all the acute care hospital beds in New York. And by the way, Trinity Health was one of those. Trinity, in fact, is one of the largest health systems in the nation. So inevitably, decision-making starts to shift from the local community to the headquarters of these big health systems. So what happens? Well, here's a good example. A few years back, the Montefiore Health System in the Bronx took over Mount Vernon Hospital and said, oh, it's going to be much better and better quality and better access and better everything. But now they're planning to close it, replacing the hospital with a freestanding emergency department and an ambulatory clinic. Similarly, Trinity Health has announced it wants to close Mercy Hospital, which is a safety net facility in Chicago, because it's losing too much money. So I just offered these as examples of what could happen down the road. Now, everything I just said about hospital mergers is made even more complicated when one of the merging facilities is Catholic sponsored or affiliated with a Catholic system. Catholic hospitals are accountable not only to their own CEO and board, as well as any system like Trinity that they belong to, but they also come under the governance of the local Catholic bishop. So when two hospital systems sit down to conduct merger negotiations, if one of them is Catholic, there is in effect a third party at the table, the bishop. He's not there in person, but the Catholic Health CEO, so in this case, Jim Reed, who I know quite well, it has to shape the transaction so it will pass muster with the bishop. As Michelle said, Catholic hospitals operate under these ethical and religious directives. They are updated periodically, and when that happens, it can cause problems for compromises that have been previously negotiated in Catholic secular mergers. You're going to hear more about the ERDs from Dr. Debbie Stollberg and Glenn Northern from Catholics for Choice. So I'm not going to go into those in detail. Are there ways to protect the delivery of key services like reproductive services at community hospitals that are merging with Catholic hospitals? Sometimes. But I'll be very honest with you, the track record of these solutions is not great. For example, when Samaritan Hospital in Troy, which was then part of Northeast Health Partners, joined the St. Peter's Health System some years back, I worked very closely with Dr. Jim Reed, who was then the CEO of Northeast Health, to try to figure out how could we protect the provision of postpartum tubal ligations in the hospital's maternity unit. And Dr. Reed, to his credit, really worked hard on this to try to create a separately incorporated hospital within a hospital that would not have to follow all of those ethical and religious directives. It was called the Burdett Care Center. And it worked well for a period of time. However, that solution fell apart after several years due to financial issues and loss of key clinicians. So Burdett Care was then absorbed into Samaritan Hospital and came under all of those Catholic directives. There are some examples from elsewhere in the country of solutions to protecting access to these services in Catholic secular mergers. There's one model from California that I know Dr. Jim Reed is familiar with. When non-Catholic hospitals join the Dignity Catholic Health System, they've been allowed to continue providing postpartum tubal ligations, contraception, and gender-affirming surgeries for transgender people. But they've all been required to ban abortions and death with dignity, which is an option in California and could be here in New York sometime soon. Moreover, Dignity recently merged with a more conservative Catholic health system called Catholic Health Initiatives. And the review of that merger requires the Common Spirit Health, which is the product of that merger, to keep the reproductive health services going at those non-Catholic hospitals for 5 years. That's it. So after 5 years, they could go away. It's really important to insist on full transparency of the terms of hospital mergers, particularly Catholic, non-Catholic ones. Sometimes hospital executives, and I've heard them all over the country, will tell community groups, oh, don't worry, we won't let that happen. Or don't worry, physicians will be able to give full counseling about contraceptives in their own offices. But then those promises are not actually reflected in the merger documents and can be difficult to enforce. So I want to say a little bit about the process by which this merger would have to be approved by the state and what you can do to weigh in. So transactions like this one must be submitted to the New York State Department of Health for review and approval through a process known as Certificate of Need, or CON. An important stage in that process is consideration by what's called the Public Health and Health Planning Council. Honestly, this whole review and approval process is not very transparent or consumer friendly. I published a whole study documenting this a couple of years ago. So for example, there is only one consumer representative on the 24-member Public Health and Health Planning Council, which is chaired by the Vice President of Northwell Health System, the biggest health system in the whole country, or whole state, I should say. And it's very difficult to submit public comments to them. They're doing their meetings virtually now, and you have to type them into a chat function, which I know we're using here, but it's not very helpful when you're trying to talk to public officials about something that will affect your healthcare forever. Moreover, the full Certificate of Need application submitted by hospitals is not available through the Department of Health website. In the past, we've sometimes been able to get hospital executives to give us the full CON application themselves. And I would put that on the list for you to ask your hospital executives to give you. So I'm happy to work with the leadership of this coalition to raise consumer concerns at many steps along the way as possible and get responses from hospital executives documented in the official record of state review. In some cases, we've been able to attach conditions to the state approval of the merger. So I want to conclude with my advice to you as people in Schenectady County who are concerned about this. My first piece of advice is ask a lot of questions about how your access to healthcare would be affected, not just now, but in the future. Speak up about the services that matter to you, and ask those merging hospitals to give you a complete copy of their Certificate of Need application well in advance of consideration by the Department of Health and the Public Health and Health Planning Council. So thank you so much for the opportunity to share these things with you, and I look forward to the rest of this forum.
Lois, thank you so much for those remarks. And Michelle, thank you. Just want to remind folks that we're going to have a number of speakers. We're going to stop at various points during this event to ask some questions. If you have a question to ask, please type it in the chat box. We'll be calling on folks to ask their questions live if we know that you have a question that you want to ask. Raising your hand, unfortunately, isn't going to work during this format. So make sure that you type your question in the chat and we'll get to it at the appropriate time. We are going to hear next from Dr. Debbie Stollberg, and then we'll have some questions for the doctor before we bid her farewell for the evening. So we'll have Dr. Stollberg speak next, do some questions and answers, and then go on to the rest of our speakers. I am so pleased to introduce to you Dr. Debbie Stollberg. Dr. Stollberg is a longtime colleague in the work to try to protect reproductive health care from Catholic health restrictions. She was a family medicine resident at West Suburban Hospital in Illinois when it was taken over by the Catholic Resurrection Health System. Since then, she has become one of the nation's leading researchers on the impact of religious restrictions on patients and doctors. Dr. Stollberg, can we hear from you?
Hi, thank you for having me. You can hear me okay? Great, thanks for having me. So I am still a practicing family physician in Chicago and the chair of the Department of Family Medicine at the University of Chicago now. And as Corinne said, I first learned about this issue myself when I was in my family medicine residency. The hospital that I chose for residency was specifically really community-based hospital, had a longstanding commitment to public health, to working with the community, and specifically to pregnancy-related care. There was a maternal child health program taking care of people with high-risk pregnancies. And that was part of what made it a great fit for me and my interest for residency. One night, my first year of residency, while I was on call, my attending physician and I had a quick break to go grab a meal. And as we were sitting there eating, he said, "So did you hear that we're going to be working for the Pope?" And I had not heard. I knew that the hospital, as an independent community hospital, was in some financial struggles and was potentially looking for a partner. But I had no idea that it was considering a big Catholic system. Over the course of the next few weeks, months, and years, I learned and really saw firsthand what that meant for us as trainees, for the nurses and doctors and other practitioners who work there, and most importantly, for our patients that relied on this hospital. One of the first things that came to light, as several of you have mentioned, is that patients could no longer get a tubal ligation when they decided that they didn't want to have any more children. And that included people that had been getting their whole prenatal care with a provider at our clinic, and had talked with their doctor, with their midwife, and agreed that this was what they wanted. This was a good plan for them. And then they came into the hospital to give birth and were told, "I'm sorry, we're now operating under the ethical and religious directives for Catholic healthcare services, and we can't provide you with this tubal ligation." In some cases, even if the patient was having a C-section, meaning that they were undergoing surgery and the fallopian tubes were right there and could have gone through the procedure, and instead the doctor had to complete the C-section, so the patient back up and tell her that she could schedule for another time 6 weeks later, a few months later, including having to go through another round of anesthesia and the risk that comes with that. Not to mention just the difficulty of having a newborn and what that means when you're expecting to have all of your needs taken care of in a single hospital visit. So that was a real loss right away. And then the other thing that we started to see is that people who came in with unexpected complications of their pregnancies, that the full range of options that had previously been available to treat their complications were not necessarily available under the ethical and religious directives. So for example, we had a patient who came in and was diagnosed with an ectopic pregnancy. And she was given the options medically to treat the ectopic pregnancy, which is life-threatening for the pregnant woman, and cannot progress to term and have a life-born baby from that kind of pregnancy. She was given the options to get a medicine called methotrexate or to have a surgery. And she wanted to have the medicine, and the doctor, who had just gone through the required training by the Catholic system for what was allowed and what wasn't, said, "Well, we can't do that here. So I'm going to actually recommend that you check yourself out. It's going to look like against medical advice, because we would never send you out with this life-threatening condition, but we're going to recommend that you go someplace else." So that was really alarming. And then a little bit after that, a patient came in, and unfortunately her bag of water had broken before, just relatively early in the second trimester of pregnancy, before the fetus was viable. And the doctors were able to tell her there's really, unfortunately, no way that this pregnancy is going to be carried to term. And previously, they would have been able to offer her choices, including starting medicine to induce labor. And even though the baby wouldn't have survived, it would have prevented her from the risk of infection or heavy bleeding. And in a couple situations, the OBGYN was told that unless the woman's life was imminently at risk, they could not start those medicines anymore. So given the situation that I observed and, learning that this was not unique to our hospital, when I finished residency, I went on to do a fellowship specifically focused on medical ethics and also public health research. And this has been an area that I've studied and I've talked to a lot of doctors about, and we've surveyed women about what they know and what they want. And I'll just briefly share some of the findings from that research, and then happy to answer any questions before I have to hop off at 1:30. In our research, talking to physicians around the country and other people who provide healthcare during pregnancy, it is really clear that these experiences at my hospital were not unique to our specific bishop or our specific Catholic system. Specifically, people not being able to get a tubal ligation, including at the time of a C-section and having to have a second surgery, is one of the most consistent and sort of distressing denials of care, that physicians report, that women report. And then the imminent miscarriage situation, for example, again, when someone's bag of water has broken and they're advised that it's really too early for the fetus to be viable, or that they're due to some risk to them, they decide that they don't want to continue the pregnancy given the risk, that often they're told there's nothing you can do except watch and wait unless you start to show signs of infection. And then some Catholic hospitals do allow at that point for medicine to be offered to speed things up. So I really do feel that there are situations where women's lives are put at risk. And they're not always even told that other hospitals where they could go would offer them a wider range of options. Lastly, my colleague, Professor Lori Friedman, who's a sociologist, and I conducted a national survey of reproductive age women and asked, what would people expect if they went to different hospitals, and what do they want to know before deciding where to go? And two things come out really clear. One is patients want to know. They want to be informed about what will be offered. And that really cuts, it was like 3/4 of women said it was, somewhat or very important to them to know about these restrictions, these religious ways in which the religion of the hospital could impact their care. And that cut across, the religion of the person answering the survey, it cut across their political affiliation, where they lived, any personal characteristics. Really, everybody wants to have the information they need. That doesn't mean they always have choices. So that's another thing, is sometimes your insurance restricts where you can go. Sometimes, that's the hospital that has the NICU level of care you need. So even with good information, people don't always have all of their choices available to them, but at least going to Lois's point, not just the transparency in the process, but I think it's really important to push for holding hospitals accountable for really sharing with the public what the public can expect when they come to this hospital. And the other side of that is that as much as people want to have that information and want to be informed consumers, we just don't. So if any of you are saying, as I did as a resident, I had no idea, I knew that I wouldn't maybe go to a Catholic hospital if I needed an abortion, but I had no idea that if I had a pregnancy complication, I couldn't get it treated, or that if I needed birth control or family planning services, that I might not be able to get those if my doctor works at a Catholic hospital. People just are not aware. And so I think, again, it's great to see hundreds of people showing up to be engaged in the issue and to learn what it would mean for yourself, your family, for your community. And I just echo what Lois said, and continuing to ask questions before, during, and after, so that everyone can go in able to advocate for themselves and get the services they need. And I'll pause there.
Debbie, Dr. Stollberg, thank you so much for those remarks. We're going to stop here and take some questions because we know that Dr. Stollberg has to leave us at 7:30. And I know that we've already got a number of questions coming in here. I just want to remind everyone, put your questions in the chat box. We'll either try to call on you or we'll read your question if you'd like that. I've got a question from Selwa Khan. Can we unmute Selwa Khan or Selwa?
Hi.
Great.
Yeah. Okay. My question is, in situations of sexual assault, how will access to medicine to prevent a pregnancy or services to terminate a pregnancy be affected by the merging of a Catholic hospital with a non-religious one? Will these services be affected by this merger?
Lois, do you want to take that or do you want me to?
Well, I was just going to say that New York does have what's called an EC in the ER law that requires all hospitals to offer emergency contraception to rape victims. And there was a special provision put in that law to address concerns from the Catholic Conference of New York State. So Catholic hospitals in New York are allowed to, if they wish, administer a pregnancy test to determine whether the woman is pregnant or not. And if not, they can offer it confident that in the view of the Catholic Church, and of course in the view of science, it would not cause an abortion. And Debbie, you could say more about that.
Yeah, and that's great that there's public policy in New York. I will say that in Chicago, this was one of the big issues that came up with our merger. And I guess I want to broaden the question a little bit. So people of all stripes and all situations need emergency contraception at different points. So I would think beyond people who have been assaulted and think about other situations where emergency contraception is really medically appropriate and supports reproductive autonomy. Beyond that, also just, I wonder about the hurdles that people sometimes have to jump through to get it because emergency contraception is time limited, like medically, and how, you know, there's a 5-day usually time window in which it's effective. And for some methods of emergency contraception, it's really much more effective if you get it in the first few days. You don't want, what happened in our hospital is that the compromise they said is that the Catholic hospital said, well, we have a doctor from a local clinic who will always be on call. So if someone comes into the ER at our hospital that needs emergency contraception, we'll call that doctor. And then as long as they write it on the prescription pad from their clinic rather than the hospital, they can get it. And maybe we can find some money to help them get a cab to the local pharmacy. And like, time is ticking, you know, for the patient. So that is a concern if the method of providing it delays it by a lot. But I'm hopeful in your situation that wouldn't be the case, but just something to keep an eye on.
Great, thank you. And thank you, Selwa, for your question. I just want to give a little bit of a warning here. Some of the questions that we'll hear next could be a little disturbing. And so I just want to remind people that we do have counselors on the line. We've got resources in the chat box. Well, I'll ask my colleagues to repost those now. Just know that these questions that come next have to do with the loss of children. So Gabriella, I know that we got a question in the submitted to us and they'd like you to read it. Would you go ahead and read the next question?
Yes, thank you. And Amy put it in the chat in case anybody wants to follow along. I'll read it out loud. Some years ago, I experienced an ectopic pregnancy scare. While I waited to find out if I was in mortal danger, I wrestled with the fear of having to choose between my life and an abortion. As a Catholic, the idea of abortion hurt, but not as much as the fear of my 2 young sons losing their mother. While I mercifully did not have to face that choice that day, I have thought about it a lot since. Catholic hospitals are only allowed to end a pregnancy through an indirect abortion via a salpingectomy or removal of the fallopian tube. Will women have to choose to sacrifice an organ and possibly some future degree of fertility to save their lives?
I can hop in quickly and say that, first of all, for the question, I'm really sorry for for the scary situation that you were facing, and it's a relatively common one, and I think scary for anyone going through it. There's different interpretations. I think the questioner said it exactly right, that the Catholic teaching is that direct abortion is never allowed. Direct abortion is really not a medical term. That's it's a religious term about what constitutes the taking of embryonic life. But whether or not, like the medicine that I was mentioning that came up at our hospital, methotrexate, giving that constitutes a direct abortion or not, I think is still an area of active debate among Catholic theologians. And so there are some hospitals where it's allowed, where the full scope of treatment options is allowed, and some where it isn't. And again, you know, are patients told that, or are they just told you need a surgery? There also are some medical situations where the medicine isn't the best treatment if the pregnancy is farther along, and where surgery would be recommended medically. So it can get complicated, but I come back to the, I guess, to me, the principle that the patient should be told all of her medically reasonable options, and especially, again, given the time sensitivity of an ectopic pregnancy, really be given information and access to a place to get the option that works best for her.
Thank you for that. And Gabriella, we've got another question that you've been asked to read that was submitted to us. Yes?
Yes, thank you. At what should have been a routine mid-pregnancy appointment, we got devastating news. No amniotic fluid, and our baby was missing key organs. Our doctor recommended inducing labor or having a D&C. This moment of having our baby was one I had imagined many, many times. No one had ever talked to me about the possibility of not having her. And certainly no one had ever talked to me about the possibility of having an abortion. No one ever told me that not having a baby or needing an abortion was as much a part of being pregnant as having a live baby. Because Bellevue was only 20 minutes from our house, my entire family was able to travel to the hospital together. I can't do adequate justice to describe the kind and compassionate care my family received at Bellevue, a hospital we knew, with my own doctors. Easy access to healthcare was exactly what my family needed. My grief and stress over terminating a much wanted pregnancy was already a lot. If I had been forced to travel to an unfamiliar hospital with an unfamiliar doctor and unfamiliar staff, it would have devastated me. Bellevue and its compassionate staff carried me and my family through. How will families continue to receive local access to all forms of pregnancy care, including care to help terminate a pregnancy? Will they be able to obtain the type of compassionate and supportive care I received?
Dr. Stollberg, what has your experience been in situations like this? Where do people turn?
It really depends on the community. And I think one of the important things to recognize is that if you get a little farther along in pregnancy and then you need to end the pregnancy for whatever reason, sometimes that it really is safest to do that at a hospital-based clinic or a clinic that really has advanced capacity. Many early first trimester abortions done either with a pill or procedure are very safe to do in an outpatient setting, in your family doc's office, done by your midwife. But as you get farther in pregnancy and the procedure, whether it's medical or whether it's like a D&C, D&E type procedure, sometimes does need more monitoring, higher level of anesthesia, the option for IV or blood transfusion or those kinds of things. And so I think while outpatient clinics can do a lot, also having that connection to a hospital that can manage complications is really important. So that's, again, another set. I don't know the specifics of what will be available locally, but those would be some questions I would ask.
One more question that we got for you is, how are decisions made at Catholic hospitals if the pregnant person's life is at risk? What do the ethical directives say about that?
Yeah, so there's a ethical principle that is not unique to Catholic ethics, but is held up in Catholic ethics, really given center stage, called the principle of double effect, which says that when any kind of treatment or intervention can have a good effect and a bad effect, how do you decide which course of action is the ethical course of action? So in this case, if a pregnant person's life is at risk and there's a treatment that can save the pregnant patient, but ends the life of the fetus, that's the setup for the principle of double effect. And there are conditions that have to be met in order to say that doing that intervention, the good outweighs the bad, essentially. And one of them is that the harm has to be at least proportional. So that's where I think you often get the practice that, for example, a woman whose bag of water has broken fairly early in pregnancy and where saving the fetus is not possible, but there is still a fetal heartbeat. And so, you know, the Catholic perspective says we still have 2 living patients to take care of. Is the pregnant person in imminent risk comes down to, is it proportionally important? And so where in non-Catholic settings, often the conversation with the patient about here's your options and here's what is likely to happen, here's the prognosis in this situation, leads to it would be better to treat you early. Let's not wait until you get an infection. Let's not look for that fever to start or that white blood cell count to go up. Let's, you know, at least offer you the option to start that treatment earlier. But the principle of double effect and that reasoning of having 2 living patients to care for often translates in Catholic settings to there's really not anything we can do other than watch and wait unless you're in imminent risk.
Dr. Stollberg, I'm going to ask you one more question before I know that you've got to jump. And for those of you, as Ali said in the chat, for those of you who didn't have your question answered here, we'll have an opportunity later. We are running behind schedule, but I'm confident we'll make it up. Dr. Stollberg, someone is asking for non-cisgender people dealing with pregnancy, and I would imagine other health issues. How have you seen religious hospitals treat them and their partners?
Yeah, it's a great question. And I think the range of experiences with reproductive health care that non-cisgender patients have is, I guess I want to say, we all have stuff to learn about what it means to be respectful. And this is not something that I would put just on Catholic hospitals, religious hospitals. I think, you know, it's an area of importance and that the healthcare community really still has a lot of learning to do. But there are some specific things that Catholic hospitals have a track record with. And it's really more around gender affirming treatment and the ability to access the medical treatment to have your physical self align with your gender identity. And there are stories, and I know Lois has been involved and can share some. There's some public testimony from California when Dignity was talking about forming a partnership with the University of California Health System of a transgender man that was trying to have surgery and had a whole plan to have a hysterectomy and was denied very clearly for religious reasons on the basis of his being transgender, right, like the day before his surgery. And that is not unique. He's not the only one who's experienced that around the country. And so I do think care for LGBTQ patients is, again, something that we have to keep asking about and really shine a light on and hold hospitals accountable to equitable care.
Thank you so much for that. And thank you for participating in this forum. I know you've got to go, but you've been a tremendous help to all of us tonight. And I hope you have a great evening.
Thanks for having me. And I want to say I'm certainly not the only person here tonight with experience with this. So a lot of questions among the folks I know certainly can be answered by Lois and Glenn and others. So thank you.
Thanks. It is my pleasure now to introduce to you Arthur Butler. Arthur Butler is the Executive Director of the Schenectady County Human Rights Commission. Butler helped found the Capital District African American Coalition on AIDS, serving as their Executive Director for 17 years. He also worked for Hunger Solutions New York and as the National Project Coordinator of the Framework for Dialogue USA. Arthur, I'd like to turn it over to you.
Thank you, Corinne. And thank you to all of the speakers that have gone before me. I'm going to try to make up some time. What all of the people on the roster has to say is equally important. And you know, if I was in a pulpit, I would ask and say a prayer of invocation, inviting the Holy Spirit to guide my tongue and to be with me as I speak to you. And so while waiting, I did that as well. So my role tonight on tonight's forum is to speak about access to equitable healthcare. And just basically for those who know and may not know, that equitable healthcare means that all individuals have access to affordable, high quality, cultural, linguistical, appropriate care in a timely manner. So I'm going to ask you to follow me through my comments and to follow me through a personal healthcare lens. And I may not, as I said, get to everything, but our helpers will make sure that what I don't get to will be put up in the chat for your consideration. The Robert Wood Johnson Foundation cited in a report that who we are or who you are influences your chances of receiving many specific healthcare interventions and treatment. So your healthcare depends on who you are. I want you to think about that just for a moment. Who you are depends on what type of healthcare treatment that you will receive. Another wise person once told me that truth will bring you to the doorstep of denial. And when faced with the truth, you'll have two choices. Either you will embrace the truth and walk through, or you will deny the truth and remain stuck. So I'm just going to go over some truth tonight so that we too can make that decision whether we want to move forward or stay stuck. So here's the truth, and Michelle said this earlier, and some of the other speakers will continue to go over it, but here, I just want you to hear a few things. One is that our dental program at Ellis is going to be eliminated. That will include the clinic on McClellan campus and also the residency program that provides emergency dental care. The dental clinic, the dental program will be eliminated. The dental clinic sees 12,000 to 15,000 patients per year. This includes the developmentally challenged and disabled patients. The vast majority of patients are low income, Medicaid, and the uninsured. A coalition of dentists from Ellis program and the community stepped up and are working with Ellis and Hometown Health to work out a solution. That's important. It looks like Hometown Health will rent the current clinic at McClellan until they're ready to expand to a bigger dental space of their own. Yet still there will be a loss. Low-income families lose the choice of where they go. Remember, your health care depends on who you are. So I lose my choice, and I also lose an additional part of who I am. Elimination of Ellis hospital-based residency program also means that as of July 1st, there will be no emergency dental coverage for Hometown Health or former Ellis dental patients. Loss of dentists, able to clear patients for surgery. These are losses that will impact our community. The visiting nurses services will also be eliminated. Now, hometown health care, home health care is extremely important to our most fragile residents. The coalition will check with the administration periodically to make sure that our patients are successfully transferred to new caregivers. But here's a loss. In a community that has faced so many losses, we find ourselves in a similar predicament where we continue to lose. And that's important because as we look at mergers, and I think coalitions are great. The coalition that I'm a part of is doing great work. As the doctor invited us to do was to ask, or Lois invited us to do was ask many questions. Don't wait to ask the questions. We're very thankful that we've been able to ask the questions because we're concerned about where the residents of Schenectady County, where the women of Schenectady County, where the low income of Schenectady County, where the elderly of Schenectady County, where the homeless of Schenectady County, where and what will happen once this merger takes place. So again, keep your lens on and keep looking through this and think about the loss. I know when we talk about mergers, we sometimes think about it in terms of profit. And so profit dictates the decisions that we make sometimes. But in a quote by Simon Sinek, he said that panic causes tunnel vision. Panic causes tunnel vision. Calm acceptance of danger allows us to assess the situation and see the options more clearly. So my hopes for us tonight is, and moving forward, is to move with calmness, assess the situation, and work towards the solution, not based on profit, gain or loss, but based on human value, the value of one's life, the character of one's being. Who I am depends on the type of healthcare that I will receive. What type of interventions will be afforded to me. Not the ability to pay, but what happens to me beyond the merger. And again, I say that we're glad that people are stepping up and Hometown Health is stepping up and others are stepping up and St. Peter's and its partners are working, but we want you to also consider the human value to the decisions that you're making and how it will impact. See, I'm fortunate to have grown up at a time when I can remember Sister Ellen Lawler and the women and the sisters who ran St. Peter's Health Hospital. I had a lot of family members who worked at St. Peter's Hospital and some who still work there. And I remember a different feeling when the sisters were being pushed out and business was being pushed in. And some of those nuances that around charity and around care and around human dignity started to be pushed aside to allow for profit margin. I'm going to end with this because I want to make up time, and I think that I've given you enough to think about. There is a scripture that says that if I had the gifts of prophecy, that if I could speak in the tongue of angels, but I did not have compassion, I did not have love, I would be a tinkling cymbal, a gong, a bong. I would not have the things needed to carry me through this journey. In a community that has faced so much loss, what we give them through our actions, what you will give them through your engagement, what you will give them through your commitment to look at the human factor, those are the things that we hope will last forever. Will you walk through the door of once faced with denial, embrace the truth, and move to a place of freedom? Or will we just leave behind a group of people to continue to suffer in a place where they have seen so much suffering? So really, I think that without preaching, I will end it there and let some of our other speakers go on. But who you are depends on the type of healthcare interventions and treatments that you will receive. To have individuals have access to affordable, high quality, culturally and linguistically appropriate care in a timely manner is important. It should be at the forefront of the decisions that we're about to make. Thank you for allowing me to share with you tonight.
Arthur, thank you so much for those words. I'm really pleased now to introduce you to Nikita Hardy. Nikita Hardy is the Affirmative Action Manager for Schenectady County. She is a well-respected, highly recommended political strategist and community engager with over 14 years of progressive experience, including having held dynamic roles within legislative, state, and local government. She recently has taken on several endeavors to further impact marginalized communities. Most notably, her passion for birth justice and breastfeeding advocacy led her to organize Capital Region Black Breastfeeding Empowerment Network, as well as her committed research on maternal mortality of Black women in America. She is an advocate, an educator, a public speaker, a full spectrum doula, and a policy enthusiast. And we are very lucky to have her with us this evening. Nikita.
Thank you so much, Corinne, for that great introduction. Hello, everyone. Good evening. I am so happy to be here amongst my neighbors, amongst my community for this forum. So low-income women, those in rural areas, and Black women and women of color are disproportionately affected by the expansion of Catholic healthcare systems and the religious restrictions they impose on women's healthcare. One study found that pregnant women of color are more likely than their white counterparts to receive reproductive health care in a facility governed by Catholic directives. I've had the opportunity to speak with our local Planned Parenthood about their capacity with facing a merger such as this. And our local Planned Parenthood clinic has had some transition lately because the umbrella organizations merged to form Planned Parenthood Greater New York, which I will refer to as PPGNY. Personally, I've spoken with the leadership overseeing our local clinic, and they have assured us that there is adequate staffing to absorb patients with family planning needs. That includes birth control and pregnancy terminations. Right now, they work with Bellevue in making referrals to each other and sometimes Albany Medical Center. They expect for this to continue. They have also assured us that their healthcare services will continue as well, their LGBTQ plus healthcare services. There is a strong commitment from the newly merged PPGNY to our local Schenectady clinic for all of these services, and we will continue to monitor this during this time. There are some things that Planned Parenthood cannot address. One, the local clinic does not have the capacity to perform tubal ligations, which needs to be done under anesthesia. It's not the same as going to a trusted OBGYN or midwife who has privileges at Bellevue. And what if already under the care of an OBGYN or midwife, and there are problems with pregnancy? Would they allow for a person to receive emergency medical care? I have a couple stories to share with you today. And I just wanted to touch on how, this is an issue that is magnified for persons in marginalized communities and low income. The accessibility is magnified, these barriers are a great hindrance. One of the stories I will share is personal in nature in regards to the heavy collections of fees for persons of marginalized communities. My father, the late Richard Bowen, was an immigrant from Trinidad and Tobago in 1979, and he worked very hard when he came to this country as a young boy with my grandparents. Unfortunately, he had to deal with some chronic ailments in his life. And the last year of his life, he spent it up here in the Capital Region so he can be closer to his grandchildren. He passed away in October of 2019 at St. Peter's Community Hospice. They provided great care to my dad, and he left us dignified. However, in my role now, it's like the universe is just giving us these different examples and lights to what we are facing right now. Because while we were planning this coalition, I was home and my husband notified me that somebody came to serve my dead father from St. Peter's for a bill. He passed away in their facility. My poor Black father, who was on Medicare, they knew he was dead, but we see with these numbers who tend to be heavily impacted by these collection actions, right? And that's something that, we wanted to highlight, that story as an example. That's my personal story, but there are many stories like that out there. There was a story shared with me. As you know, I am a doula, and we had a situation where someone who was in a domestic violence situation with her spouse, who found herself being pregnant with her seventh child. She was, and trigger warning, she was continually raped by her husband. And she went to St. Peter's to get some care. She wanted to terminate the pregnancy, and she was turned away. Fortunately, she was able to go to Albany Medical Center to get the care that she needed. And this is something that is possible, very possible, because it has happened. For her, it's great that she was able to go elsewhere to get the care that she needed. But when we look at Ellis Hospital, and we look at if things change and that is taken away, where will people go? In my role, in my community work, in my role in the county, I was made aware that we have a lot of people who have never left the county of Schenectady. We have people who have never left the city of Schenectady. If we put these barriers up, how is it that we expect for people to receive the care that they need? It is inhumane. And I share that with you because, you know, we'll hear time and time again, we can play a recorder. These stories are all out there, but these are lived experiences. And, you know, as a community with Ellis Hospital being a community hospital, we have to keep this in mind. And I'm really grateful to be here and to speak for those who are unable to speak for themselves.
Nikita, thank you so much for sharing your experience, and my heart goes out to you for the loss of your father. There's nothing like that experience.
Thank you so much.
So our last speaker this evening, last but not least by any means, is Glenn Northern. I am so grateful that he's with us this evening. Glenn Northern leads and implements Catholics for Choice U.S. activities, including advocacy, outreach, policymaker education, legislative analysis, and collegial relationships. He directs CFC's Catholics in Public Life project, a nonpartisan public education initiative that helps Catholic policymakers in the U.S. clearly articulate pro-choice positions grounded in progressive Catholicism and sound public policy. He oversees CFC's strategic relationships with pro-choice Catholics, policymakers, and reproductive health providers, religious and secular activists, and collegial organizations to inform and influence debates on sexual and reproductive health rights, social justice, and religious liberty. Before joining CFC, Mr. Northern led constituency building and advocacy efforts at Planned Parenthood Federation of America and the Religious Coalition for Reproductive Choice. He holds a degree in political science and women's studies from the Williams College in Williamstown, Massachusetts. We're so grateful to have you with us this evening, Glenn. Please.
Thank you. I am very, very honored to participate tonight. My name is Glenn Northern. I grew up in New York. I was an altar server at our small Catholic church in New York, and my family and dear friends still reside there. Now, as Corinne said, I'm the director of Catholics for Choice, which is a DC-based nonprofit that really works to lift up the voices of the majority of Catholics in the US and around the world who, as a matter of faith, disagree with our church hierarchy around issues of reproductive health and rights, contraception, abortion, LGBT rights and justice, and the role of religion in the public sphere. While the hierarchy is obviously an important part of our church, they alone are not the church. New York's 31 plus bishops by themselves are not the church. The approximately 70 million Catholics in the US and 7.2 million Catholics in New York together, we are the church. And we support access to comprehensive reproductive health and trans-inclusive services. Catholic healthcare systems purport to uphold the mission of taking care of the poor, aligned with our very central Catholic teachings around social justice. In some ways, they do. In other very significant ways, they fall short of those Catholic ideals and can deprive communities of much needed healthcare services. My colleagues before have mentioned a bit of the ethical and religious directives, and they've mentioned that they are not based necessarily in medical practice, but on standards written by the bishops. And this is not something Catholics agree with. Catholics disagree with these policies. In recent polling, 90% of Catholic voters disagreed with individuals being denied healthcare because of their sexual orientation or gender identity. So as the question earlier about the treatment of transgendered individuals in Catholic hospitals and their ability to get trans-inclusive treatment, Catholics actually support that, but Catholic hospitals will not. Nearly 70% of Catholic voters disagreed with the idea that Catholic hospitals be allowed to use religious beliefs as a reason to deny patients access to certain medical procedures and medications. So again, you know, the fact that in Catholic hospitals who are following the ethical and religious directives, access to contraception is prohibited. Often in many fertility treatments are prohibited. Abortion is prohibited. These are things that Catholics would like to see hospitals do. They feel as though it is necessary to treat the patients with the care that they need. And essentially they anchor these things in our own Catholic tradition in sort of three important pieces. One, the idea of conscience. Catholics are called to follow their conscience. We view it as both a beautiful gift and a solemn obligation, and we deeply respect the right of others to follow theirs. It's sacred, but it belongs to an individual and not a building or a hospital or an institution. It's really only something that an individual person possesses and something that an individual can choose to follow. The second piece that sort of really grounds sort of Catholic support for comprehensive reproductive health care services is religious freedom. We as Catholics recognize that we live in a pluralistic society in which many religious beliefs coexist, and for each of them to flourish, none can be singled out for special treatment by the government. It's critical that actors in the public sphere working for the common good play by the rules. When Catholic hospitals refuse to provide important healthcare services that are needed by the community, despite receiving taxpayer dollars, they fail to serve the common good. Moreover, in a pluralistic society, taxpayers' choices about the care they receive should not be prescribed by religion over individual medical needs or individual religious freedom. Both the staff and the patients in Catholic hospitals are religiously diverse. It is wrong for the Jewish patient or the Muslim patient or the non-theistic patient who enters the door of the hospital seeking care to be denied services based on religious doctrine that not even those of the faith agree with. Just as it is wrong to force clinicians to adhere to rules that go against their individual conscience. We at Catholic for Choice believe that's immoral and a blatant violation of the religious freedom of Catholics and non-Catholics, providers, and patients. Finally, Catholic hospitals often don't live up to important aspects of our own faith's teachings about social justice. Our faith teaches compassion and a preferential option for the poor. We're called to feed the hungry and tend to the sick. The consolidation of hospitals around the country and the rising prevalence of Catholic hospitals can leave many without other options and threatens to rob individuals of important healthcare choices. And as Nikita was already saying earlier, Black and Indigenous people of color who already face enormous difficulties in accessing healthcare, they're some of the folks who are most harmed by these policies. Frankly, this is the opposite of what Catholic social justice looks like. So for those of you who are following tonight, some of you are Catholic, some of you are people of faith, some of you are not. Know that you're not alone as you begin to question and think and continue to ask questions of the institutions. You are surrounded by others from many religions and non-theists who care about each other and essentially call our hospitals to ensure that they address the needs, the health needs of the community. I know some of this may have come as a bit of shock to folks, the stories that folks shared. Keep that in mind and let's commit to taking care of each other by staying engaged and in educating each other and speaking up. And tonight is one of those opportunities. Thank you very much. And I'm very honored to be a part of this conversation.
Glenn, thank you so much. I'm going to turn it over to Michelle to do some comments before we open it up to questions. Michelle?
Corinne, sorry about that. As I mentioned at the beginning of the evening, many of us recognize that Ellis needs a partner, and we respect Ellis administration's choice and the trustees' choice of St. Peter's as its partner. Our goals for tonight were to educate all of you, the stakeholders, about the benefits and risks of this partnership to our community. And two, to specifically educate the stakeholders, about the risks that religious restrictions affect patient care. Three, to shed light on expected gaps in services and what Ellis, other providers, and community members are doing to make sure that we have access to those services elsewhere in the community. And lastly, to highlight the disparate impact of the elimination of these services, the outsourcing of these services, and those religious restrictions. A lot of the information did end up in the chat, so I hope you'll take a moment and make sure that you catch it. But of course, it is available for recording later on and on Facebook. We hope that you found this evening's forum eye-opening. For many, aspects of this partnership are troubling. However, the important goal of tonight's forum is to provide the decision makers at Ellis and St. Peter's information so that they can use this information to address our community's concerns. We hope that they structure their partnership and include in their contracts an application to the Department of Health terms that minimize and protect us from those risks. Namely, that means making sure that what they have promised to us is spelled out very clearly in those documents. In addition, that there's an oversight mechanism so that we're able to check in to make sure that those services are actually being provided and not subverted. And lastly, to have an enforcement mechanism, some entity that can enforce and make sure that those services do in fact continue at Ellis locally. All right, so I'm going to, before I turn it over to I think Corinne, I'm going to just say thank you, Corinne, so much for all that you've done to organize, to lead us, and to moderate tonight.
Thanks, Michelle. I appreciate that. We have so many amazing questions in the chat. I can't even, thank goodness we've got some folks on the back end helping me navigate it. But I have to say, I had an order and then I saw a question that I just have to get to because Glenn, as some other people have acknowledged, I myself am Catholic. I'm also so excited that I got an appointment for a vaccine on March 23rd. I can't believe it. But Shelley Hegan asks a question that's been on my mind all day as I saw the news reports of some Roman Catholic leaders calling the Johnson & Johnson vaccine problematic from a moral perspective. And I'm wondering if we can unmute Shelley to ask her question. Shelley, are you there?
Yes, hi. I am here. Yeah, I just was asking the question in the context of, you know, the COVID virus is going to be with us for a very long time. So getting through this moment is obviously a challenge and getting everybody vaccinated, but should this merger go through, and I live in Troy where we also no longer have access to a secular hospital, will those places be able to provide vaccines on a go forward basis, especially through not just the hospitals themselves, but their extended physician practices? Should those vaccines, as we develop more and more mRNA vaccine technology, will those vaccines be available to people who utilize the St. Peter's health systems throughout our community?
Yeah, Lois, I don't know if that's something that you can address or if it's just a question that we're just going to have sit out there, either Lois or Glenn.
I don't know, Glenn, you're probably more up on this controversy.
Yeah, so the piece that I can say about this is that the bishop's response with the vaccines, or a number of the bishops, because it's not all of them, but a number of the bishops have been incredibly irresponsible around this. When you think about I think about the African-American community, and I think about sort of some of what's happening in New Orleans, where the Archdiocese basically said that it would be better if folks tried to take the other two versions of the vaccine and not use the Johnson & Johnson version. And I think about the African-American community's difficult relationship with the medical community already. I feel like that is an incredibly irresponsible response to have to the community there, when everyone is working really, really hard to try to get people vaccinated. And I think the worry is that bishops would be heavy-handed both in their application in other places, and that they might actually encourage folks to so I think that is sort of the greater worry around this. I don't know that I can speak to what would happen there in particular.
I think it's an open question, and it's so we've talked a lot about reproductive health and LGBTQ inclusive care. We've gotten a couple of questions in the chat about end-of-life care, and I want to see if Kim Callanan would like to unmute her mic and introduce herself and ask a question.
Sure. So I'm Kim Callanan. I'm the president and CEO of Compassion and Choices. And we do see the impact that the Catholic ethical and religious directives have on people's ability to access end-of-life care, far beyond just death with dignity or medical aid in dying. And I was curious if any of the panelists could speak to this to be sure that that becomes a part of the community's awareness about the impact this merger could possibly have.
Lois, do you want to take this one?
I could start, and maybe Glenn can help too. Honestly, the biggest impact has been in the states that do have death with dignity, like California, Washington, Oregon, hopefully New York one of these days, if Corinne is successful. There, we've seen Catholic hospitals and health systems actively prohibit their employees or physicians with admitting privileges from being able to, not only can they not help a patient access death with dignity, they can't even really talk about it or counsel about it or refer patients elsewhere for it. And that's a big problem. That's a huge problem. What the other thing that can sometimes be an issue is ceasing nutrition and hydration. That can be a choice that people who are terminally ill would want to make. And I think there's mixed record about that in Catholic hospitals.
Glenn, is there anything you'd like to add?
Yeah, I don't know that there is, other than I believe that is, certainly a misinterpretation of Catholic doctrine. And that, again, Catholics wouldn't agree with that, even if it is the policy of the ethical and religious directives.
What it comes down to is the prohibition on euthanasia. And so how does that get interpreted by the bishop, by the ethicists at Catholic hospitals? I am not currently aware of any problems at St. Peter's Health Partners, but I haven't been living in the Capital District for some years now, so perhaps other people have something to say about that, but it's not something that I ever encountered.
Michelle, do you have anything you want to add, or we turn it back to Kim and see if she's got any follow-up comments? Michelle?
The only thing that I would like to add is from folks I've talked to who have had loved ones in care at St. Peter's at the end of their life, and especially in the hospice program, St. Peter's has been very respectful of personal wishes and followed the most forms. So I don't know if that helps.
That is helpful, I think.
Okay.
Kim, is there anything you want to leave us with?
Yeah, so I'll just add, in our experience, the issue does go far larger than end-of-life care. It's any action that the person would want to take that would intentionally hasten their death. And so this, and to be clear, Catholic health systems have, tremendous ability to do pain management and to relieve suffering. So that is not to suggest that people can't get good care. But if the person, for example, has the early stages of dementia and they want to voluntarily stop eating and drinking, Catholic systems will not support them with palliative care in order to access that as an option. Or if they're closer to if they're at the very end of their life and they want something that will accelerate, like the withdrawal of care, those are decisions that are being made through the ethics committee as opposed to through the person's personal wishes. So we hear all the time of stories where people are at the end of their life, and inevitably when they share the story of their loved one not getting the care that they wanted, by the end of the story, it comes through that they were at a Catholic health system. So it is interpreted different across different health systems, but we do see the issue going far wider than just death with dignity or medical aid and dying.
Thanks, Kim. We'll definitely have to keep our eye on that issue as this moves forward. We have a number of questions in the chat and coming into us from elsewhere, from religious folks who are saying, how in a community that might be left with only a Catholic hospital, how are the religious views of patients who are not Catholic respected? And I think I want to call on Reverend Jonathan Vanderbeck to voice this question. Maybe you can scoop up some of the other questions into yours. Reverend, are you there?
Yes, I am. Thanks. I'm just scrolling back to find my question again, because we've had so many great questions in the chat. So just give me one moment to find mine again.
Maybe Allie or Gabriella can help and send.
Yeah, I have it. Here we go. Thanks. So I'm an openly gay ordained minister who serves in a local congregation here in Rotterdam. And I often counsel other LGBTQ individuals in my congregation and other LGBTQ people of faith who are navigating the integration of their faith and LGBTQ identity. We have research that indicates that LGBTQ people who face rejection, particularly from non-affirming families or religious institutions, do have an increased risk of self-harm and suicide. And in fact, religion and strong religious adherence, which is often seen as a protective factor for individuals with suicidal ideation, is actually seen as a risk factor for LGBTQ individuals. So this means that this includes things like being denied for medical services, such as gender-affirming surgeries, hormone therapy, pregnancy surrogacy, as well as matters of dignity, just in how patients are treated, such as using appropriate pronouns, respecting gender identity and gender presentation, and access to allowing same-sex partners in decision-making. I'm concerned particularly that the faith of some branches of Christianity could therefore cause harm to members of my congregation and members of the LGBTQ community who are also people of faith. I guess what I'd be looking for is what sort of assurances do I and frankly hundreds of other LGBTQ people of faith have that our faith values will be respected? How is that, how are those matters of kind of progressive faith brought in when we're talking about honoring faith and spiritual care?
Wondering, is that a question for you, Lois? Or Glenn? Glenn, why don't you start?
I can tackle part of that. So I think there is reason to be worried. So frankly, while there's nothing in the directives that directly speaks to the LGB part of care, when it comes to trans-inclusive care, and actually there isn't something directly about in the trans-inclusive care, with the exception of the fact that certain procedures they're not going to actually do them. I think many hospitals have a fair amount of work to do around the care that they provide to LGBT individuals. And I think it's exacerbated in a Catholic system in which, again, there is care that you're not going to be able to receive. And then the whole idea of an individual's conscience and being treated with dignity. While that is something that Catholic hospitals actually started out as these very small institutions that were, treating Catholics who at that point in time were actually discriminated against. And then they've grown into very, very large entities. And some of that mission is sometimes lost in terms of the social justice mission that they really originally set forth. Yeah. Lois?
One specific, I guess, kind of example that I can actually cite is had a individual in our congregation, not actually a member, but kind of adjacently connected to our congregation, who is transgender and is on hormone therapy, and suffered a mental health crisis and was referred to the inpatient unit of Ellis. And the individual reported that there was initially some significant pushback even from Ellis on allowing the individual to continue on their hormone therapy while in the psychiatric unit of Ellis. It required some advocacy on behalf of this individual's therapist and some other members in the community. I was concerned by that. The reasoning, of course, was, well, we want to get the individual off all their substances so we can stabilize them, which that alone kind of indicates a lack of educational awareness around how we treat and serve members of the trans community. I'd be even more concerned if that had taken place at an organization like St. Peter's, who, again, right, if this is what we're seeing in Ellis pre-merger, what could we possibly be seeing post-merger when already these issues are actually at play currently in our community?
Reverend Vanderbeck, thank you so much for that question. I think you'll hear me say vigilance through this forum. I think it's going to require vigilance on all of our parts to make sure, that people in our communities are treated with respect.
Thank you.
That you mentioned. So thank you for asking the question. I want to ask Omar McGill to unmute himself. He's got a question that I think is for Michelle. Omar?
Definitely. Thank you for acknowledging me. Thank you to this organization and this group for continuing doing this work that is much needed in our community for people who depend on Ellis Hospital to provide the services that are much needed within our community. My question is, eliminating the dental program and visiting nurse service, outsourcing the emergency department, and limiting the reproductive health care, it's all so much, right? And I'd like to thank Arthur Butler, who I serve with, who is the executive director of the Schenectady Human Rights Commission, which I serve on as well, for talking about how much these decisions will affect people living in the neighborhoods who might not be able to go somewhere else like Albany for their care. I would like to know, are there any other programs that are going to be eliminated or outsourced? And if so, how will we find out about that? And how can we ultimately prepare for those other programs that might be eliminated?
Thank you, Arthur. Actually, that's a great question. So I don't doubt that there are other services that are going to be either eliminated, outsourced, or what have you. I think we're going to be losing services. And I think there's two really good examples of how we have dealt with that as a community. So if you first take the dental program, it was being eliminated, and it wasn't made public that it was being eliminated, but folks who work in the clinic, teach in the clinic, found out. They created their own coalition, and they tried to get attention to it. They brought attention to it. They did a lot of outreach, And now they are working with Hometown Health, with leaders at Ellis to make sure that gaps in services are filled. And when they still see gaps in services, they're still pushing for it. So, and then I think another really good example is visiting nurses service. When that was eliminated, it was made public. It was straight in the paper in the Daily Gazette. We could all see it was happening. And in the article, there were reassurances that actually all of the patients were going to be transitioned to new caregivers. And as a coalition, we've checked in with them periodically to make sure that that's happening. And there's been a real commitment to follow the plan that they filed with the state to make sure that they don't wind down visiting nurses service until every single patient is transferred to a new caregiver. So I think what's really instructive about those two examples is our community can handle it. When we are brought in and told about things, we step up, we help with the problem. We have a lot of resources in our community, which is pretty phenomenal, and people that are willing to roll up their sleeves and give their own minds, expertise, resources, funds to really support our local hospital. And nobody freaked out. You know, the visiting nurses service could have been a blow, but it wasn't, because they were honest with us and they told us the plan. And I think everybody took it pretty well. So I'm hoping that moving forward, if there are more issues that come to light, that folks who are either inside Ellis will bring it to our attention, or if other community members find out about services that are being eliminated or outsourced, they'll also bring it to our attention, because there is a lot that our community has to add to this. Thanks.
Thank you so much.
Great. We are running out of time. We have so many good questions, though. It's really hard for me to pick here. I think we have a question about whether people have the right to sue if their medical needs aren't met because of ethical religious directives. And I'm wondering if maybe we can answer that question in the chat. And I have some questions for Michelle, but I'm going to do that when I turn it back over to her. And I want to see if maybe Sarah Barron wants to unmute and ask the last live question here. Sarah? Sarah?
I'm here. Thank you so much for this opportunity to speak. I heard my brother in faith, Jonathan, ask a question, and I heard Glenn even add more to it as he was speaking earlier. But the assumption seems to be that the directive from the Catholic bishops is what will happen. How do we protect the rights of people who are people of faith but are not Catholic, of people of faith who are Catholic but don't agree with their bishops, and of people who are not people of faith but have a sense of their own conscience and what needs to be done? And I think this becomes particularly imperative. Well, I guess it's all over the place, from rights of the dying to I was recently a woman who received care at Bellevue, and I received care that the Catholic Church would not give me. So how do we protect other people's integrity and faith and wisdom?
And I think with that, thank you, Reverend Barron. I really appreciate that question. Michelle, for me, this question really touches on so many of the other questions that we're getting in the chat. People are frustrated. They're expressing frustration, and they're asking, one, what they can do. They're asking if does Ellis have any other options. They're saying, you know, they worry that if this merger is defeated, St. Ellis pulls the plug and we're out a community hospital altogether. So there's a lot of worry that I'm seeing expressed in the question in the chat. And I think Reverend Barron's question leads nicely into what can we do? And so I'm going to leave you with the last word on that.
Thank you. So I will more fully address the Reverend's question, but first I'd just like to remind everybody that we have a sense of ownership on this, right? I mean, this is our community, these are our bodies, and yes, there are things that we can do to to really address some of the issues that have been raised tonight. So the gaps in services that have been identified, which are quite a few. Like I mentioned, we've got folks in the community that have great resources. Talk to each other, find them, bring them to our, the coalition's attention. We can support people who can find solutions, have ideas for solutions, bring them up, even if you don't have the resources necessarily to take on a project, pass along any ideas you have to try and fill those gaps in services. And I think what we didn't talk about all that much was the outsourcing of the emergency department and the collection practices that were put in the chat of St. Peter's in particular. So both of those issues have the potential of really devastating our families financially when you talk about price gouging or aggressive bill collection and the prevalence of medical bankruptcies really across our nation, but in our community as well. So I think what would be very helpful is if people experience any of that at the emergency department, say after April 1st, when Envision takes over there, bring it to our attention. We need to know, because we need to stay up on top of that. There's a federal law that should help, but we need to know to be able to address it. Ellis is going to have its own public forum, so please attend that, because you've raised all of these concerns and you deserve answers. And depending on how they answer those questions, we'll see if we need more forums, frankly, and maybe we need more time to talk things through, let them know our priorities have not been addressed. There will be an opportunity, as Lois mentioned, to offer public comment once they do file at the Department of Health. And hopefully they'll have provided us those documents in advance so that we can look and see what objections we have. That's probably one of the best ways to get your opinions known and your priorities and any objections known. And what Reverend Barron talks about is really the core problem here, right? It's figuring out how to address the fact that we need a community hospital that's viable long-term, and we needed to have core services, and core services should absolutely include reproductive health care, right? So, and comprehensive reproductive health care that's patient directed. So it's going to be a struggle, and we're going to have to keep pushing on the hospitals to figure out a solution, frankly. That's our best bet. There are vehicles to do it. Lois mentioned other examples across the nation. So it's not foreign. This can be done. And it is critically important, as everybody has mentioned in the chat and the Reverend brought up, we have our need to abide by our own conscience, right? And we deserve that. And we deserve to be able to make our own healthcare choices. So with that, Corinne, I think you probably have a way to tie things up for us, if you wouldn't mind. And I again want to thank all of our panelists and you as well for moderating, and all of the attendees. Thanks.
Michelle, thank you so much. What occurs to me is what I thought about right before this event started, that I feel like more questions were raised than we could possibly have answered this evening. But I think that this gave us a good introduction to what challenges we'll be facing here in the Capital Region, and particularly in Schenectady, as we look at limitations on the availability of affordable health care. I think it's really important what someone pointed out in the chat, that if we had access to universal health care, which is, it's just undeniable, it would go a long way to reducing healthcare disparities. It would go a long way to allowing all of us to get the respect and the dignity, as Nikita said, that we all deserve from our healthcare system. So this is not a forum about the New York Health Act, but there is a New York Health Act in New York. And if you want to learn more about it, just Google it. There's plenty of material out there. I think that we're probably looking at scheduling another forum. This is not the end. So many of you, we couldn't get to call on your questions, and you have really important voices here. And I want to encourage you to get involved. And I think folks are going to be pasting in the chat ways for you to keep in touch with the Schenectady Healthcare Access Coalition so that you can be informed of the next steps and what we're hearing as we hear it. I want to thank everyone who made tonight's important event possible. To Michelle, to all of our speakers, Lois Utley, Dr. Debbie Stollberg, Arthur Butler, thank you so much. Nikita Hardy, thank you for sharing your stories with us this evening. Glenn, thank you for gracing us with your presence this evening, and for hosting this event and all the support that comes with taking that on. Thank you so much to the Sanctuary for Independent Media and the People's Health Sanctuary, to Steve Pierce, Brenda Miller, Melissa Bromley, and Xavier Coughlin. And thank you to all of you who took your time this evening to participate and to learn. Your questions, your attention, and your continued vigilance are much appreciated. Thank you so much.